Yes, doctor.
Okay, thank you very much. Having a very good morning, and I know that all of you are waiting for your final results. The result is done and it's just sent for the final signature. And once it is with me, I will announce it maybe today or tomorrow. But inshallah, don't worry about that results. I know you did well and you work hard for the exams, and then it's your right to know your results. Uh, have seen the results, and I can say this that result is very good. Uh, it's much better than your previous course results, and inshallah, all of you will be happy with the results. Anytime today, maybe, and maybe tomorrow, I'll get it, and immediately I will send it to you for your approval. Just one last minute request that the questionnaire is with you, and today is the last date. Yani, we'll stop the questionnaire today. So I request you, those who haven't filled yet, just complete it because this is for our quality assurance. We want to know which area we need to improve, and this is like as a feedback from you for the course as well as for the tutor, so that we can improve on it, we can work on it, and we can come back with some better outcome. So once again, thank you very much for your patience with us. Now let's see this topic today. This is anterior abdominal wall or anterolateral abdominal wall. Abdomen is one of the very important topic in this course, nutrition and metabolism. Whether it is ECE, like yesterday you look how to examine the abdomen, and then we let you know about the anatomy of the abdomen. So it's a very important topic. Please concentrate with me and you read it many times. It's beginning and is one of the most important topic for you to understand the anterior anterolateral abdominal wall. We'll also have the posterior abdominal wall, but we'll concentrate on the anterolateral abdominal wall for now. So there is one small advice before we jump to the discussion, that how to how to read the topic. You have a lot of content and you always struggle with reading all the content at a time, and then you forget it, and then you again read it and then forget it. So how to read the things so that you can remember it for a longer time? There is one very small advice, and that is when you are reading any topic, any particular topic, before that you just know why you are reading it. What is the importance of this particular topic? I'll let you know different topics in the anterolateral abdominal wall, and I will give you the importance of that particular topic. So before reading that topic, if you know the why you're reading, what is the importance of this particular area or particular topic for your clinical practice, then you are going to memorize it. Your brain is going to keep it with you. Just for example, like there are so many things happen with you, but you remember some important things and you forget those who are not important. The similar thing happens with the reading. So while you are reading, just know the importance, background of that particular topic. If you know the background, if you know the importance, the why you are reading this anatomy, then you are going to remember it for a very long time. So let's start with now. The first thing that should come to your mind when you're reading the abdominal anterolateral abdominal wall, that what are the different abdominal regions. Why to know the regions? Why to know the regions? Because in like I said, whenever you are reading something, you should know why you are reading it. So why the abdomen is divided into 9 different anatomical regions. If you go to the clinic, the patient will come to you with the problem in the abdominal wall, or like say the pain in abdomen. So as a clinician, you should know that from where this pain is coming. Patient, like in the last case, there was epigastric discomfort. So you should know where is the epigastric region is, and the likely the pain is coming from, what is the source of this pain. So if it is epigastric, or it is umbilical, or it is other regions, if the patient is complaining that he or she is having pain in that particular region, you should, as a clinician, know that from where this pain is originating, what is the source of this pain. So that's why we have divided abdomen into 9 anatomical regions. So what are those region? This is imaginary. You will not see this 9 region when you see the abdomen. When you examine the abdomen, you will not see that we have this region mentioned there. This is a plane, but we have imaginary lines. How many? We have two vertical and two horizontal imaginary lines. And with these 4 lines, we divide the anterolateral abdominal wall into 9 different regions. Very important for you when you go to the clinics, when you examine the patient, you should know that which region of the abdomen you are examining. Because the patient will complain of the pain, and the moment you start examining the patient will complain of tenderness. So the pain is a symptom and tenderness is a sign. When you have these signs, you should know that what could be the possible underlying pathology. So for example, I will give you one example here. Now, let's see what are the different regions. We have 9 regions by 2 vertical and 2 horizontal lines. What are the 2 horizontal lines? We have we have transpyloric and transtubercle line. I'll let you know what are the transpyloric and transtubercle line. And then we have 2 vertical lines. The 2 vertical lines are passing in the middle of the clavicle, and we call it as a mid-clavicular line or mid-clavicular planes. So these are the 4 lines, 2 vertical and 2 horizontal. And with this, we divide the abdomen into 9 different regions. So now you can see that here we have here, if you can see here, these are 2 vertical and these are 2 horizontal line. And with this horizontal line, we have 9 different regions. So in the center, we have the umbilical region. Below this, we have the pubic region, and above this is the epigastric region. Now, right to the epigastric, we have hypochondrium region. So right hypochondrium here and the left hypochondrium. Similarly, on the right and left side of the umbilicus, we have the right flank and the left flank. And then we have the right groin and the left groin. Similar thing here. We have this umbilical region. Above this is epigastric. Below this is the hypogastric, another name. Then on the right side of this, we have hypochondrium, right hypochondric, left hypochondric. And then these are the lumbar region, right lumbar, right iliac fossa, and the left iliac fossa. So these are the 9 different regions. Now, I'll give you one example because this week you have read about the epigastric pain. So this is your epigastric region. The patient is complaining of pain in this region. So we have different organs here, maybe stomach, maybe duodenum, maybe liver to some extent, and then we have some extra gastric like the cardiac causes. Right iliac fossa, umbilical, these are specific for some organs. So you should know when the patient is complaining of the pain in the particular area. You ask where is the pain exactly. This is, when you take the history from the patient, the first thing ask that what exactly the location of the pain. Like in the mind and movement, you have the consultation where you have to ask the patient that where exactly the pain is coming from, what is the exact location of the pain. So if the patient is complaining of the pain in the right iliac fossa specifically, then you think of the organ which are located in the right iliac fossa. Like very common is appendix, and appendicitis is the cause for the right iliac fossa pain. It's very common. Similarly, you will come to know that in each region we have a different organs, and that organs can, if inflamed or if there is any underlying pathology, can lead to pain or the tenderness in the overlying region. So we have different regions, 9 regions. And when you go to the clinics or the hospital, you will see the note that the patient is complaining of the pain in the right iliac region or the right iliac fossa. So you immediately understand that the consultant or the specialist is talking about which region. If they'll ask you, go and palpate the right iliac fossa of the patient. So you should know exactly where is the right iliac fossa. So it's very important, not just for anatomy, it's very important for your clinical practice, that once you go to the clinic next year and you start examining the patient, you should know where is you're examining, what you're examining, which region you're examining. the umbilical region. The moment you put your hand on the umbilical region and the patient complain of the pain, that you can write that there is a tenderness in the umbilical region. So you should know where exactly the umbilical region is. So similar for these different 9 regions. So you can say that there is a tenderness in the right hypochondrium. So what could be the underlying pathology here? We have here the liver. So if there is hepatitis and you examine the patient with hepatitis, and you will see that the moment you push your hand in the right hypochondriac region, a patient start complaining of the pain. So the likely source of this pain is from the liver, and there is under the liver we have another important structure, that is the gallbladder. So the pain may be coming from the liver or from the gallbladder. So these are very important pathology. You should know every day you will see these cases. Appendicitis, you will see cholecystitis, you will see hepatitis, and then you have to examine the patient and you have to know which region you are examining. So in the right side, we have the liver, and on the left side, we have the spleen, the left hypochondriac region. So if the patient is complaining of the pain in the left hypochondriac region, as a clinician, you should think that the pain is coming from the spleen. If there is a splenic trauma, a splenic injury, and there is a tenderness over this region, the likely source of this pain is the spleen. So, as a clinician, you should know the different regions, and you should know that what organs are inside and what could be the underlying pathology if the patient is complaining of the pain in the specific region. So this is anatomical division, very important. You will get the question like this, that the patient is complaining of the pain in the left hypochondriac region for about 2 months, and so and so. So, and then you should know where is the left hypochondriac region is. So this is the abdomen. This is the anatomical division of the anterolateral abdominal wall by 2 vertical and 2 horizontal line. Now, apart from that, the clinician, the surgeons, they divide the abdomen simply into 4 different quadrants. So they call it right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant in a simple version. This is also acceptable for, like, say, if you say the pain is in the right lower quadrant, so you should know where is the right lower quadrant is. So simply dividing the abdomen into 4 different quadrants, 9 quadrant according to anatomical. It's still practiced in the clinics. It's not that if you say right iliac region, it's wrong. But there are 2 different ways. One is anatomical division by 2 vertical and 2 horizontal lines, and one is simply by dividing the midline and then crossing it through the umbilicus to divide this into 4 different regions. So this is one very important thing about the abdominal regions. We have 9 divisions anatomical and 4 divisions clinical. Now let's see. As I told you that we have 2 vertical planes and we have 2 horizontal planes. So what are the horizontal plane? I told you that we have transpyloric plane, very important plane, and this is one of the horizontal plane that divide the abdomen. So they'll ask you about this. What are the things you have to know about this plane? First is that at what level this plane passes, and second is that what are the structure you will get at this level. If you are talking about a transpyloric plane, what are the abdominal structure you could find it here. So first thing first, the vertebral level is the lumbar vertebra 1. So you have the thoracic vertebra, and just move from the thorax to the lumbar L1. You will see at a lower border of L1, or between L1 and L2 or L1, you have this transpyloric plane. And this transpyloric plane, when you see this from anterior to posterior, this is a plane. So when you see this from anterior to posterior, it passes through the different structure. And one is, you know, uh, one is the ninth costal cartilage. So let's see, it crosses the tip of the ninth costal cartilage anteriorly. And then what structure is called transpyloric. So it it crosses the pylorus of the stomach. So you must have seen or you must know about the different parts of the stomach. We have the fundus body and the pylorus. And this transpyloric plane at the level of the L1, it crosses through the pylorus of the stomach. That's why it is also called as trans. Trans means through. Through what? Through the pylorus of the stomach. So this plane which passes through the L1 vertebra also crosses what? Pylorus of the stomach. What other structure you have at the L1 level? Hilum of the kidney, neck of the pancreas, fundus of the gallbladder, lower border of the spleen, end of the spinal cord. You remember the spinal cord in the last module, minor movement, you have read it that the spinal cord ends at the level of L1. So they are very fond of asking the structures found at the level of L1, and we have the end of the spinal cord, origin of the superior mesenteric artery, the portal vein. So these are some of the important structure that you will get it at the level of the L1, that is transpyloric plane. So two ways. They'll ask you what are the structures found at the transpyloric plane, or the other way of asking is that what are the structure that can be seen or that can be found at the level of L1. So vertebral level as well as the transpyloric plane. This is called surface marking of the abdomen. Very important. Transpyloric plane passes through the L1, and we have some very important structure that could be seen or that could be detected at the level of L1. Transpyloric plane at the level of L1. So this is the first, and then we have another horizontal plane. You can see it that this is crossing through the lower border of the L5 and it's tubercle here. So this is called transtubercle. Tubercle of what? Tubercle of the iliac crest. This is the iliac crest and it is crossing the tubercle of the iliac crest. This is called transtubercle plane and it passes through the lower border of the L5. So these are two horizontal plane, and then we have two vertical plane. These vertical planes are mid-clavicular. Mid-clavicular, yani midpoint of the clavicle and downward. So we have right mid-clavicular and we have the left mid-clavicular plane. So two vertical plane, two horizontal plane. Very important to know about the transpyloric plane and what are the structure that could be found at the level of L1. Okay. So now we have seen the different regions of the abdomen, and now we are going to see what are the layers of the anterolateral or anterior abdominal wall. Layers of the anterior abdominal wall. Why it is important to know about the layers of the abdominal wall? As a surgeon, Yani, most of you wanted to be the surgeon, and in surgery, most of you wanted to be the general surgeon or gastroenterologist. So if you want to go inside the abdomen for like say, is there any pathology in the abdomen? So you have to enter the abdomen, you have to open it. This is called laparotomy. So once you want to dissect the abdomen to go inside, you have to know what are the layers of the abdominal wall that you are likely to cut. Say like, for example, you want to make a mid section here, and then you should know that what are the layers you are going to cut. So what are the layers of the anterior abdominal wall? So we have a skin first, as you know, everywhere. And deep to the skin, we have superficial fascia and then we have deep fascia. Now here the superficial fascia is divided into two different layers. One is called superficial fatty layer and another is called deep membranous layer. So superficial fatty layer is called Camper's fascia and the deep membranous layer is called scarpa fascia. So here is the difference here. Underneath the skin, we have the superficial fascia, which is further divided into two layers. Superficial camper, C is first, so it's superficial fatty layer, Camper's fascia, and inner membranous layer that is called scarpa fascia. It's important. You will learn later that what are the importance of these superficial fatty layer and deep membranous layer of the superficial fascia of the anterior abdominal wall. Now, so we have a skin, we have superficial fascia, which is again divided into two layer, and then deep to the superficial layer, we have deep fascia. The similar arrangement everywhere, a skin superficial fascia and the deep fascia. What are the difference? I told you that a superficial fascia is divided into two layers and the deep fascia is not very prominent. It's like a vestigial. It's not very obvious, unlike other places you will have the deep fascia. So deep fascia here is very deficient, you can say. It's not very strong. So why deep fascia is deficient in this region? Because abdomen is meant for distension. When you eat and when you drink the abdomen, there is a distension of the abdomen. And this distension, if there is, if there is, if there is no deep fascia, if there is no deep fascia, it will allow you, it will allow you for the distension. But if there is a deep fascia, it will not allow you, because deep fascia, the tough structure, is collagenous, right? So if there is a deep fascia, it will not allow the abdominal distension, especially in the female. For like pregnancy, there is a huge enlargement of the abdomen. It's about more than 42 centimeter, 42 inch. And that is because the abdomen, there is a less amount of deep fascia, which allow the abdominal distension. So you can say that the deep fascia is deficient, is very primitive, is not strong. So this is one difference. So we have a skin superficial fascia, deep fascia, and then what do we have deep to the deep fascia? We have muscles and aponeurosis. And then we have what? We have the fascia, that is called fascia transversalis. And then we have extra peritoneal fat. And the last thing is that we have the peritoneum. Now, peritoneum is made up of two layers. One is called the parietal layer and one is called the visceral layer. We will learn about what is the difference between the parietal layer and the visceral layer. But, the last thing is peritoneum. Say, for example, if you want to go to the stomach, so you will see the parietal layer and then the visceral layer of the peritoneum. So these are the layer you have to dissect. You have to cut the skin, superficial fascia, deep fascia, the muscle and their aponeurosis, fascia transversalis, extraperitoneal fat, and the peritoneal layer, the parietal layer and the visceral layer. Now, so these are the different layers of the anterior abdominal wall. So we have skin, superficial fascia, deep fascia, and the muscle. Now we'll see what are the muscles we have of the anterolateral wall. Now we can divide the muscles of the anterolateral abdominal wall into two groups. One is called anterior group because it is anterolateral abdominal wall. So we have anterior group and then we have the lateral group. What muscle do we have in the anterior group? We have one straight muscle in the abdomen, and the straight is called rectus. You have learned about so many rectus in the minor movement, like rectus femoris. You have read about the rectus muscles of the eye. And then we have here in the abdomen, one straight muscle. So rectum is straight. And then this rectus muscle is in the abdomen. So simply we call it as a rectus abdominis or rectum abdominis. Now, nomenclature, don't just memorize the name of the muscle simply. You have to understand that why these muscles are called so. Or you can name yourself that we have two anterior group of muscle straight and then we have the lateral group of muscle. So what should you call these muscle? One is your rectus abdominis or rectum abdominis, and then one is based on the shape, which is a pyramidal shape. We call it as pyramidalis. One rectus abdominis and one is called pyramidalis. These are anterior group of muscle. Then we have the lateral group. They are oblique. One is external, one is internal, and one is transverse. So we have three lateral group of muscle, external oblique, internal oblique, transversus abdominis, and two anterior group of muscle, that is rectus abdominis and the pyramidalis. Now, these are the origin and insertions. Uh, we are not very fond of asking, but you have to know from where these muscles are coming. And what is the nerve supply, and what is the action of these muscle, 5 group of muscles. Okay. Now we have this external oblique. Now this one is the external oblique, and you can see that their direction is oblique, and these are the most external. So these are the external oblique group of muscle. The first outermost muscle is the external oblique, and it's like when you're putting your hand in, under your pant, this the direction of the finger is like external oblique. Look at the direction of this fiber. So it is going from above downward, and it's the most external. So the direction is oblique, right? So this is called external oblique. And then we have, where is the attachment of this muscle? This is from the linea alba. What is linea alba? This is a central white fibrous structure, fibrotendinous structure. This is called linea alba. And then these muscles are coming from there, and then it's get attached to this one. So extend from xiphoid process to the symphysis pubis. Here is your xiphoid process, and below is the symphysis pubis. So this linea alba extend from here to there. We have another important structure that is called inguinal ligament. So what is inguinal ligament? You have seen this in the minor movement, that this is the ligament from anterior superior spine to the pubic tubercle. This is called inguinal ligament. And then once it is attached to the pubic tubercle, it's reflected over the pecten pubis. And this reflection is called lacunar ligament. So the two things, one is the inguinal ligament, which is from anterior superior spine to the pubic tubercle. And then this, after it is attached to the anterior to the pubic tubercle, it is reflected over the pecten pubis. It is backward reflection. And this is called lacunar ligament. So three important landmark here. Just remember this. I'll let you know why it is important to know. One is the anterior superior spine, one is the pubic tubercle. And to these is attached what? The inguinal ligament. And from here, there is a reflection, backward reflection of the inguinal ligament that we call as the lacunar ligament. So here we have the pubic tubercle, and medial to the pubic tubercle, we have the pubic symphysis. So one very important point here in the superficial, in the marking, what is the mid-inguinal point and what is the midpoint of the inguinal ligament. So when I say midpoint of the inguinal ligament, I'm talking about the midpoint of this ligament. And this ligament is where? From where to where? From the anterior superior spine to the pubic tubercle. So it is somewhere here, the midpoint of the inguinal ligament. Don't get confused. The midpoint of inguinal ligament is between what? It is the midpoint of the inguinal ligament, which is between the pubic tubercle and anterior superior spine. Now, when I say mid-inguinal point, so what is mid-inguinal point? So mid-inguinal point is between anterior superior spine and the pubic symphysis. So it is somewhere here. It's larger, right? So this region is called inguinal region. This region is called inguinal region, and we have here inguinal ligament, which is between anterior superior spine and the pubic tubercle. And when I say mid point of the inguinal ligament, I'm talking about the inguinal ligament only. But when I say mid-inguinal point, it is between anterior superior spine and the pubic symphysis. So three important bony landmark here: anterior superior iliac spine, pubic tubercle, and pubic symphysis. And two confusing point. One is what is a midpoint of the inguinal ligament and what is the midpoint of inguinal region. Okay, so just remember these things. Lacunar ligament, as I told you, that this is the reflection of the inguinal ligament on the pecten pubis here. And this reflection is called lacunar ligament. So what is lacunar ligament actually? It is the reflection of the inguinal ligament. Okay, so this is the reflection here. This is called as the lacunar ligament. So Then after the external oblique, we have the internal oblique, and the direction of the internal oblique is opposite to the direction of the external oblique. You remember the external oblique is from upside down, and internal oblique is from down upside. So this is oblique again, but this direction is opposite. Opposite to what? Opposite to the external oblique. And then we have the transversus abdominis. This is not oblique. This is transversus abdominis. See the fibers. It is transversely placed. So these fibers are called transversus abdominis. So outermost, this one is external oblique. Then we have the internal oblique, and then we have the transversus abdominis. So these are the three lateral muscles: external oblique, internal oblique, and transversus abdominis. You can see this one. This is your external oblique. Then we have internal oblique, and then this is the transversus abdominis. Now, come to the anterior muscle. So what anterior muscle we have? We have rectus abdominis, and then we have the pyramidalis. So let's see the rectus abdominis. Now this is your rectus abdominis from the pubic symphysis to the sternum and the costal margin. Here we have tendinous intersection. So if you see this muscle, you will see these are the tendinous intersections, and those who are go to the gym, and these muscles are strong, and you can see that they make it like it's very obvious for them. So this is the muscle, the rectus abdominis muscle. And at the lowest part, we have very small muscle, pyramidal in shape. This is called pyramidalis. It's again from the pubic symphysis, and it is inserted over this central midline fibrotendinous band. This is called the linea alba. So two anterior muscle, pyramidalis and rectus abdominis, and three lateral muscle, external oblique, internal oblique, and transversus abdominis. Now, there is one very important concept in the anterolateral abdominal wall, and that is rectus sheath. So what is rectus sheath? This is a fibrous envelope of what? Now see these muscles, the external oblique, internal oblique, and transversus abdominis, as these are moving from, these are lateral muscle, right? So when they're moving from lateral to central, the anterior region, these are converted into fibrous sheath. Now these are the fibrous sheath of this aponeurosis of this external, internal, and transversus abdominis. What is aponeurosis? These are the flat tendon. The difference between the aponeurosis and the tendon is that tendon is a round band-like structure, but the aponeurosis are sheath. So again, these are the tendon, but these are flattened. So these are called fibrous sheath of what? The external, internal, and transverse abdominis. And when they come from in the midline, is coming from one side and another side, they enclose what? They enclose these muscles. What are these muscles? We have the rectus abdominis and rectus abdominis in the anterior part. So this rectus abdominis is enclosed by the fibrous sheath of what? Of these anterior group of muscle. And then they all together, they form what? They form the rectus sheath. So rectus sheath is having the anterior wall and the posterior wall. And in between the anterior and posterior wall, we have this rectus abdominis muscle. So we'll see what in what regions we have how this anterior wall of the rectus sheath and the posterior wall of the rectus sheath is formed. But one thing is, is sure that this rectus sheath is formed by what? By the aponeurosis of the external oblique, internal oblique, and transversus abdominis. So as I said to you that we have the anterior wall and the posterior wall, and these are not same throughout. So they start from where? From the pubic symphysis to the xiphius sternum. We have this rectus abdominis muscle, and it is enclosed by what? The rectus sheath, which is having the anterior wall and the posterior wall, but they are not same. So we'll see in which region how is the anterior wall and how is the posterior wall is formed. Now there is
Doctor,
one more. Yes, please.
how many tendinous intersections do we normally have?
Uh, You're talking about this midline, right?
No, the slide before that, the tendinous intersections.
Yeah, okay. This may be, it differs. Some one, two, three, four, some have three. So it depends. Yani, most common is that four, maybe three. So this is like, it's not fixed here. We have three. It's not, four is not as prominent as here. So usually four, maybe three, or maybe more than four. But, most of the cases you have four tendinous intersections. Okay, so we're talking about the rectus sheath, and then we'll see what is rectus sheath is all about. This is arcuate line here. We'll know what is arcuate line, and you know I'll let you know what is arcuate line. Just give me a minute. Where is the arcuate line? So here is there are three important landmark here. This is if sternum, down is the pubic symphysis, and here is the umbilicus. So midway between the umbilicus and the pubic symphysis, we have the arcuate line. So I'll let you know what is this arcuate line is. Now, rectus sheath is this. As I told you that what is rectus sheath? Rectus sheath is the, it's formed by the aponeurosis of the three muscle, external oblique, internal oblique, and transversus abdominis, as they come to merge in the midline. And when they come to merge in the midline, they enclose what? They enclose this muscle. They enclose what? They enclose this muscle. We have these two rectus abdominis muscle. So now see this in the different region above the costal margin. You know where is costal margin? So above the costal margin, the anterior wall is formed by the only by the external oblique muscle. There is no other muscle. So this is only aponeurosis of what? Aponeurosis of the external oblique. I said, what is aponeurosis? It's a flat tendon. Like every muscle, there is a tendon. You have seen so many tendons, but because these are the flat muscle, the tendon also become flat. And we call these as a aponeurosis. So when they're coming in the midline, they are enclosing what? They are enclosing these two muscles. They are the rectus abdominis. So as I told you, and they're forming the rectus sheath. So as I told you, the rectus sheath is different in the different region. One is above the costal margin. There is only one anterior wall, and that is formed by the external oblique muscle. Now, above the arcuate line, I told you that there is an arcuate line which is between what? Which is between the umbilicus and the pubic symphysis. So above the arcuate line and below the costal margin. Now see this arrangement of the rectus sheath. What are the muscles here? We have external oblique, internal oblique, and transversus abdominis, right? So they are coming in the midline and they are enclosing this rectus abdominis muscle. So how is the anterior wall is formed? Is by the external oblique, and then look at the internal oblique. The internal oblique again is divided into two, anterior lamina and the posterior lamina. Anterior wall is formed by the external oblique and by the anterior lamina of the internal oblique, and the posterior wall is formed by the posterior lamina of the internal oblique and the transversus abdominis. So this is a beautiful arrangement of the rectus sheath. What is rectus sheath? It is the aponeurosis of the oblique and transversus abdominis muscles enclosing what? Rectus abdominis. So here is the rectus abdominis, and we have this anterior wall, and this is the posterior wall. Between what? Between the costal margin and arcuate line. What is below the arcuate line? Now, below the arcuate line, there is no posterior wall. We have external oblique, internal oblique, and transversus abdominis all going anterior. And this is forming the arcuate line. As I told you that what is arcuate line? The arcuate line is the demarcation between what? Between the anterior and posterior wall. So all here you will see that there is only anterior wall. There is no posterior wall. So below the arcuate line, there is only anterior wall, which is formed by all the three muscles. Here we have one and a half, one and a half. One and a half means external oblique and anterior lamina of internal oblique. The posterior wall again is the posterior half, posterior lamina of the internal oblique and transversus abdominis. But below the arcuate line, we have only the anterior wall, which is formed by all the three muscles, external oblique, internal oblique, and transversus abdominis. And this is just the fascia transversalis. You know the different layers. This is the fascia transversalis. So rectus abdominis is resting directly here on the fascia transversalis, and this is called the arcuate line. All the layers are anterior. There is no posterior. So moment you see that there is no posterior wall, this is the beginning of the arcuate line. And where is this arcuate line? Between the umbilicus and the pubic symphysis. And just above the pubic symphysis, you have, like say, they all merged together. So this is the arrangement above the costal margin, above the arcuate line, and below the arcuate line. This is the rectus sheath. Again, what is rectus sheath? Rectus sheath is your aponeurosis. It is formed by the aponeurosis of the external oblique, internal oblique, and transversus abdominis, which encloses the rectus abdominis in the midline. So we have laterally, we have these three muscles, oblique muscles and transversus muscle. And when they come to midline, they form the aponeurosis, and they enclose what? They enclose the rectus abdominis muscle in the midline. These are called the rectus sheath. So you can see that how this anterior wall is formed, how is the posterior wall is formed. This is the rectus sheath. This is the rectus sheath here. And this anterior wall is aponeurosis of all the three lateral muscles. And the posterior wall is formed by the fascia transversalis. So in the different region, you will have the difference. Now, so we have seen the anterolateral abdominal wall, the different regions of the anterolateral abdominal wall, what are the different layers, skin, superficial fascia, how is the superficial fascia is formed, what about the deep fascia, and then we have seen the different muscles, three lateral muscles and two anterior muscle. We have also seen the rectus sheath, which is the aponeurosis of the three lateral muscles enclosing the rectus abdominis muscle. Now let's see the vascular supply of the anterolateral abdominal wall. Uh, you know, umbilicus is called watershed line. What what does this mean? Watershed line. Yani below this, you have a different vasculo-lymphatic supply, and above this, you have a different vasculo-lymphatic. When I say vasculo-lymphatics, yani the artery vein and the lymph nodes are different. So below this is supplied by inferior epigastric artery, inferior epigastric vein, and it drains to the inguinal ligament here. Above this is supplied by the superior epigastric artery, superior epigastric vein, and then drain to the inguinal lymph node here. So anything above this is into the inguinal ligament, and anything below this will go to the inguinal ligament here. Beg your pardon. Anything below this will go to the inguinal ligament. Anything above the umbilicus will go to the axillary lymph nodes. So again, we have superficial epigastric artery and vein, and below we have inferior epigastric artery and vein. The superior epigastric artery is a part of the internal thoracic artery. The inferior part is inferior epigastric and deep circumflex iliac artery coming from the external iliac artery. So you remember that superior epigastric artery from the internal thoracic artery, and inferior epigastric artery is coming from the external iliac artery. It's a very important relation here. We will see now. You have seen that there is the femoral artery. There is a femoral vein, and then there is a femoral artery is crossing here. Now, the femoral artery, you will see that the femoral artery is what is a continuation of external iliac artery. So this external iliac artery gave rise to the inferior epigastric artery. So inferior epigastric artery is coming from here and it is going above. So remember this very important relation that the inferior epigastric artery is a branch of the external iliac artery, and which is here the external iliac artery become the femoral artery when it comes to the femoral triangle. So this is the inferior epigastric artery. Okay. What are the nerves? We have the intercostal nerves, lower six intercostal nerve, and then L1. What do we have? L1. L1 is ilioinguinal and iliohypogastric nerves. So these are the nerves which supply the anterolateral abdominal wall. Now, very, very important is the inguinal canal. In the lower part of the anterolateral abdominal wall, we have a canal, and this canal is just above the inguinal ligament. So we call it as the inguinal canal. This region, in fact, is called the inguinal region. So, so many things here. We call it as inguinal. The ligament is called the inguinal ligament. The lymph nodes are called inguinal lymph nodes. And there is a canal. This canal is called the inguinal canal. And this is a very, very important concept to know about the inguinal canal. Why? Because this is a potential, this is a canal and communicating what? The exterior with the interior. So inside, what do we have? We have the all the abdomen content. We have the intestine, and it's coming outside. This canal from inside is connecting what? The canal is connecting inside to the outside. So this is a potential space. So whenever there is a potential space, you're likely that some of the content might herniate, might come out through this space. And this is called the inguinal hernia. So what is hernia? It's a protrusion of normal content to the abnormal space. So the content is the normal, but it is the location is abnormal. This is called herniation. So something is like say abdominate is going inside the thorax. This is called hernia. Something from abdominate is going in outside. This is called inguinal hernia. So this inguinal hernia is very common in older people as well as the young baby. So I'll let you know what are the different types of inguinal hernia. But just now there is inguinal canal in the lower part of the abdomen just above the inguinal ligament. So when I say inguinal ligament, you know that where is the inguinal ligament? It is between anterior supericiliary spine and the pubic tubercle. Very important landmark is the inguinal ligament. Okay, so what is the length? It's 4 centimeter long. Above what? Above the inguinal ligament and extend from what? From the deep ring to the superficial ring. So where is the deep ring and where is the superficial ring? Now let's see this one. This is the deep ring and here we have the superficial ring. Before that, now here we have the pubic tubercle, right? Here we have the pubic tubercle and this is the attachment of the inguinal ligament. Now this is what? This is your femoral triangle, femoral vein, femoral artery, and femoral nerve. And then this space is there. This is called femoral canal. Okay, you remember this is lacunar ligament, reflection of the inguinal ligament. And then this space is there. This space is called femoral canal. And again, this is a potential space. Something inside might herniate through this space, the femoral canal, and then it can lead to what? It can lead to another type of hernia, and that is the femoral hernia. Again, what is hernia? It's a it's a normal thing into an abnormal space. So the content is normal, but it comes to this space, it's become the hernia. So we have two very important hernia on this region. One is this hernia. This is called femoral hernia. And then we have one hernia here that we call as the inguinal hernia. So two important hernia very close to each other. Please listen carefully. We have two very important hernia. One is called femoral hernia in this space because you have just finished this minor movement. You know about this. This is the femoral canal. It is a potential space. So something might herniate through this potential space, and this is called femoral hernia. And something might come through this inguinal canal. This is called inguinal hernia. So how to differentiate clinically? Listen carefully that if there is a patient will come to you with a bulge in this region, there is herniation. So how will you see the herniation? Herniation will look like a bulge just under the skin, maybe intestine or something like that. So if you see the bulge here, how will you say by examining the patient that this is the femoral hernia or this is the inguinal hernia? Now, what you have to do? What you have to do? I'll go and we'll see again. So this is how to differentiate between the femoral hernia and the inguinal hernia. Now let's see this. This is the inguinal canal, and we have two ring, the deep ring, and we have the superficial ring. And what are these? This is your the femoral vein, artery, and the femoral nerve. VAN, van. This you have seen it in the femoral triangle in the last model. Deep ring is where? It's just above the mid-inguinal point. And lateral to what? Lateral to inferior epigastric artery. Remember this, I have told you that this artery, the inferior epigastric artery is coming from where? From the external. This is which artery? It is going deep here. This is the femoral artery, and just above the inguinal ligament, it is the external iliac artery. And from the external iliac artery, we have one artery coming, that is the inferior epigastric artery. So this is inferior epigastric artery, and this is inferior epigastric vein. So just lateral to this, we have what? We have the deep inguinal ring, which is above the mid-inguinal point. When I say mid-inguinal point, it is between the anterior superior spine and the pubic symphysis. Where is the superficial ring? This is above and medial to the pubic tubercle. Where? So I in this slide, in this slide, I told you that this is a pubic tubercle and this is above and medial. Above and medial. This is a pubic tubercle and this superficial ring is above and medial. It's above and medial to the pubic tubercle. Now, you tell me that if there is a bulge in this region, the patient will come to you that there is a abnormal swelling in this region and you are thinking of either it could be a femoral hernia or could be a inguinal hernia. How you're going to differentiate it? Simple thing is that you just palpate the pubic tubercle. You know about it. Where is the pubic tubercle? You have seen it. Or just palpate the pubic tubercle and see where is the bulge, medial to it or lateral to it. If it is medial to it, it is the inguinal hernia. If it is lateral to it, it is femoral hernia. Because the superficial inguinal ring is where? It's medial, above and medial. So if it is, the swelling is above and medial, it is the inguinal hernia. If it is lateral to it, it is the femoral hernia. Because the herniation will come from here, deep ring, and will come through the superficial ring. So you will see that this is the inguinal hernia. And if it is lateral to this, you can say that this is the femoral hernia. This is what I told you, that this is the midpoint of the inguinal ligament and midpoint of the mid-inguinal point between anterior superior spine and the pubic symphysis, and midpoint of the inguinal ligament is between anterior superior spine and the pubic tubercle. So there is a difference between the midpoint of the inguinal ligament and mid-inguinal point. So this is just medial to this. It's not at the same point. They are not same thing. What I mean. So you know about this inguinal canal. So if it is canal, it is having the anterior wall, it is having the posterior wall, superior wall, and it is having the inferior wall. So how is the inferior wall is formed? It is by the inguinal ligament and the lacunar ligament medially only. This anterior wall is formed by the aponeurosis of what? External oblique muscle. The posterior wall is formed by the internal oblique and the transversus abdominis. And the superior wall is formed by the arching fibers of the internal oblique. So the internal oblique is passing and it is forming the superior wall. So you should know how the different walls are formed. So who will form the walls? What do we have in this region? We have what? We have the inguinal ligament, which is below. So it is forming what? It is forming the inferior wall or the floor of the inguinal canal. And anteriorly, we have what? We have the external oblique. The posteriorly, we have what? We have the internal oblique and transversus abdominis. And superiorly, the internal oblique and transversus abdominis is arching over the superior wall. So it's forming the superior wall. So all these muscle, along with the inguinal ligament, they will form the different walls. So you have to remember these things, that how these different walls of the inguinal canal is formed. Now, as I told you that we have the hernia, that is called the inguinal hernia, and we have two different types of hernia. One is called indirect hernia and one is called the direct hernia. So what is indirect hernia? It is through the deep ring, and direct is, now let's see, what is this? This is your external iliac vessel, and from this is coming inferior epigastric vessel. Remember I told you. And then this is the region. What is this area is? This is Hasselbalch triangle. And through this Hasselbalch triangle is the direct hernia. So what is the boundary of this Hasselbalch triangle? Medially, it is formed by this muscle, the rectus abdominis. Laterally, it is formed by this inferior epigastric vessels. And below, it is formed by the inguinal ligament. So anything coming from this is direct hernia, and anything coming from the deep ring and it is going to the superficial ring is called the indirect hernia. So direct hernia is through the posterior abdominal wall, and indirect hernia is through the deep ring to the superficial ring. So inguinal hernia are two different types. One is direct, which is through the Hasselbalch triangle, and you know where is the Hasselbalch triangle is this one. And one is the indirect, which is coming through the deep ring. But both are passing through the superficial ring. So we have two rings, deep ring and superficial ring. Now, this is we finished with the anterolateral abdominal wall. We'll go to the peritoneum. So what is peritoneum is, you have seen the lungs, you have seen the heart, and you have seen that they're covered with the peritoneum. They're covered with what? They're covered with the pleura, and they're covered with the pericardium. They have two different layers, right? One is called the visceral layer and one is called the peritoneal layer. How it is formed? Let's see that this is the lung and they start developing inside this balloon. So the moment it start growing, it will compress this into two different layers. The outer layer, we call it as the parietal layer, and the inner layer, which is attached to this lung. Just for example, suppose this is the lung and developing inside the peritoneal cavity. It this layer, which is attached to the lung, is called the visceral layer, and this layer, which is outside, is called parietal layer. So this is how the membranes, covered the different structure. It has two layers, the outer layer, which is called parietal peritoneum, and the inner layer is called the visceral peritoneum. Now in abdomen, again, we have, the peritoneum and discovered the different organs inside the abdomen. So we have three different types of organ here. One is called the intraperitoneal organ, one is called retroperitoneal organ, and one is called infraperitoneal organ. There is one more concept that is called in retroperitoneal organ, they call it primary retroperitoneal and secondary retroperitoneal. We'll see what does this mean. Now let's start with the retroperitoneal. Retroperitoneal means there is structure in the posterior abdominal wall. This is the posterior abdominal wall. There is structure in the posterior abdominal wall, like say abdominal aorta, inferior vena cava, and anterior to this we have the peritoneum. So they are behind the peritoneum, and this is called retroperitoneal organ. And there's some structure like a stomach, which is covered with a peritoneum from all sides, from anterior and from the posterior, to a layer of the peritoneum. So these are inside the peritoneum. Inside the peritoneum, so they are called intraperitoneal organ. So we have the stomach here, and then we have the small intestine, which are covered from anterior and posterior wall, and they are hanging from the posterior abdominal wall. So these are called intraperitoneal, yani they are inside the peritoneum. So they are called intraperitoneal organs. And then we have these organs which are below the peritoneum. They are called infraperitoneal organs. So we have three different types of organ. Intraperitoneal, that they have a proper peritoneum, both covering anterior posterior wall. And retroperitoneal organ, their only anterior walls are covered. So they are called retroperitoneal organs. So what are the intraperitoneal organs? Like a stomach, liver, a small intestine, transversus, and sigmoid colon. They all are covered with the peritoneum. You will see these structures in detail later on. Retroperitoneals are what? Are the structure which are behind the peritoneum, like kidney and most of the pancreas, your abdominal aorta, inferior vena cava, they are behind the peritoneum and they're called retroperitoneal organs. And then we have these organs which are just covered superficially. They're below the peritoneum and they're called infraperitoneal organs. Examples are urinary bladder and the structure in the pelvis, the urinary bladder and the mid part of that. So if you see the abdomen, you open the abdomen, you will see this is the transverse section. Now let's see this the peritoneal structure. So intraperitoneal structure, the first one is the stomach. As I told you that these are intraperitoneal, they're covered from the anterior side and the posterior side. So, and they're hanging from some structure. So we have omentum. This is the stomach and this is the lesser curvature and this is the greater curvature. From lesser curvature, we have the peritoneum, which is called lesser omentum, and we have peritoneum from the greater curvature that is called greater omentum. And they are covering both anterior wall and the posterior wall of the stomach. So this is intraperitoneal organ. So we have lesser omentum from the lesser curvature to the liver, and then we have the greater omentum, which is hanging down from the greater curvature. This is the greater curvature. So these are called omentum, lesser omentum and the greater omentum. Greater omentum, what is greater omentum? It is from the greater curvature. It's hanging down. It's like a curtain. So once you open the abdomen from here, from the midline, you remove all the muscle and everything. You will see what? You will see this structure. There is a curtain hanging down from the greater curvature. What is this? This is the greater omentum. It is filled with fat. So all fat is there. So you have to remove it to see what? To see the small intestine. So see this, the curtain is removed to look inside, and these are the small intestine. Then we have the mesentery. So omentum is for what? Omentum is for the stomach, and the mesentery is for the small intestine. Which part of the small intestine? Jejunum and ileum, not duodenum. Duodenum is a retroperitoneal organ, but jejunum and ileum, they are covered with the posterior abdominal wall through this curtain again, and this is called the mesentery. So you will see this, that the mesentery is attached to the small intestine, the jejunum and ileum, and they're making them attached to the posterior abdominal wall. So this is the mesentery for a small intestine and omentum for the stomach, and these are the intraperitoneal structure. So this is what we have for now. If you want to ask any questions, you are most welcome. But please go next week whenever next session, not next week, next time when you come to the lab, you see the different types of organ. One is called intraperitoneal organ, which is having the peritoneum proper, like your stomach and the small intestine. Which part of the small intestine? Duodenum and jejunum. Not, beg your pardon, jejunum and ileum, not duodenum. Duodenum is a retroperitoneal organ. Then see the retroperitoneal organs, like the organs which are in the posterior abdominal wall, that is only covered from the anterior side. They are behind the curtains. So these are called retroperitoneal organ. So in the abdomen, we have mostly two different kinds of organ. One is the intraperitoneal organ and one is the retroperitoneal organ. So this is what we have for now. This is just the introduction. You go on and we'll let you know everything. When you see the stomach and all, one by one, you will see all this structure here. So in this way we have finished this introduction to the anterolateral abdominal wall and the peritoneum. What you have to know the structure, the muscles forming the anterolateral abdominal wall, the rectus sheath. Then you have to know about the inguinal canal. Then you have to know about the peritoneum. So this is the end of this session now. If you have any question, you can ask me. And I request you, when next time you come to the lab, you please explore all this structure, the arrangement of the intraperitoneal organ and the retroperitoneal organ. Some will say that we have two different kind of retroperitoneal organ. One is the primary retroperitoneal organ and one is the secondary retroperitoneal organ. So primary retroperitoneal organ, like say the abdominal aorta, inferior vena cava, and kidney, they are behind the peritoneum from the beginning. But some structures, they have peritoneum while they are developing. But as they grow, they come to light to the posterior abdominal wall and the peritoneal is lost. So they are called secondary retroperitoneal organs. So there is not much difference. Like say the pancreas, the duodenum, they are retroperitoneal organs, secondary retroperitoneal organ. But the kidney, the ureter, The abdominal aorta, inferior vena cava, they are primary retroperitoneal organ. So don't be confused with this primary and secondary. In adult, all are retroperitoneal organ. So don't be just get away with these things. So with this, thank you very much. I will try to, you know, get the result done and release it today or tomorrow, inshallah. The result is very good. And just one thing, if you uh, if you want to review the result, like say some of you not satisfied with these results. So if you want to review it, you can review it, but you have to write a request to the vice dean that you want to review your results and you have to give it to me. And then if you're male, from the male side, you can give it to Dr. Yasir. And through the female side, you can get it done with Dr. Rada and Dr. Tasir. And give it to me. I will revise your result thoroughly. And if there is anything, we'll update you. This is what one thing, that if you want to review your results, you have to write a request through the vice dean that your ID and your name is this, and you want to review the results. And it will take some 1 or 2 weeks. And if there is anything, we'll update your results. So this is one request from you. It should come through the application through the proper channel. Second is that if you want to know the details of the marks, that how much you got it in the final MCQ, MEQ, and so on, then you have to come to us. I'll be available in my office for the male students, and Dr. Gada will be there for the female students. We cannot disclose the marks on the WhatsApp because we don't know who you are. So if you want to know your marks, you have to come to meet us, the male students to me in the male side, and the female students to Dr. Gada to know the details of your marks if you want. And if you want to review it, like say you say that you're not satisfied with somehow with your marks, then you have to write a application, the request that your name and ID is so and so, and you want to review your grades of the final exam of the mind and movement. It should come through the wise, through the program coordinator, and they'll ask me to review it. I will review it. It might take some time, but if there is anything, we'll update it. And update means what? Update means we'll review it, and if there is increase, it will increase, or if there is a decrease, it will decrease, because you made a request to review the marks, not to increase the marks. Review means we'll go back and we'll check everything. We'll check your marks, and then if there is increase, it will be increased, or if there is a decrease, it will be decreased. So I hope no one of you will come to me to make this request, because I know your marks is much better than your previous course marks. I have this marks and I compare with that. And I can see that all of you have done well, relatively well, that your previous course results. And I'm sure that all of you will enjoy this moment, inshallah. With this, thank you very much. If you want to ask anything regarding your results or regarding your the course or anything, you are most welcome.